Face, Ella.
I see these days Ella doesn't show her face at all.
Yeah, she doesn't want.
I was speaking Zulu with you, Kenny.
Sorry?
I was speaking Zulu with you there.
I heard, and I didn't understand Zulu at all. I got Sawubona, Molweni, all of the others, but hey, you are a man of many tongues.
Where is this Vuyogas Machalam?
Eh?
Where's VJ Vuyogas Machalam? Andimbona apha. Uphi sisi wethu? Wathi uphumile. Uphumile nyani. Uzabuya.
Jacobs, your curtains.
Oh, yes.
Like it. Yes, it's very nice.
Oh, I thought you said I must close it. The sun is. Oh, thank you.
Thank you.
I'm sitting in my office.
Yeah. You should thank my sister. You should thank my sister for putting these beautiful curtains.
Oh, I will. I will, my flavor.
Yes.
I can see you are behind the furniture. Which one is that? Oak.
Mahlenga. I see it here.
Furniture right now. Furniture enzima. Hayi. Ngiyakutshela. Uphi umongameli? The honorary president. You are muted. You're muted, ma'am. We says mntwana kaphinda ungene. Uphi?
Is at home at Nkonjeni.
Nkonjeni.
Yes.
The prince.
The prince.
Yeah. Uteles.
Yeah, the prince is at Nkonjeni, sitting there, keeping him warm and everything.
I can see there's also a Parliament TV here. Hey, it's busy here. Huh? There's also even TV here.
Molo sokukhatha.
Hello, ma.
Niyaphila baba?
Philile ma. Kunjani kuni?
Hayi siyaphila baba, siyaphila.
Ndiyavuya ma. Mona
Yeah.
Dr. Kenneth Jacobs.
Hey, Honorable Sukacha, hoe gaan dit?
Goed man, hoe gaat het met jou?
Goed. Is dit koud daar by julle of is julle nog nie so onder die ys nie?
Baie koud. Ik heb ook het al geval hier, so dat is koud hier. Je ziet, ik kan niet zo mijn baard verkeerd doen. Ik los het ook maar zoals jij nu.
Ja, nee, laat maar 'n bietjie tyd en 'n bietjie bly. And it helps with the cold.
Dat is wel. Hoe is het daar bij jullie?
Baie koud. Die sneeu lê hier op die berg sommer hier by my en my vallei.
Sheikh ma. Good afternoon, sir.
Is everybody okay?
Sokacha,
Thank you very much.
Yeah, baba.
Kunjan Sokacha.
That's
That's all right.
Oh, Sukacha, I see your big beard there. I see your big beard and Shaky Mom, I see you regularly shave. Whenever I see you on TV, you always shaving. Where's Shaky Mom now?
Sheikh Mom wants to stay young.
He wants to stay young, yes. But some just take the hair off their heads and you don't see the gray hair. I checked that thing out. Some people just stay.
I'm off this morning. When I look at them, I said, hey,
Mind your tongue. Jacob, mind your tongue.
But I was spot on there, Maslingo. I'm spot on. I've seen that practice.
Morning, Miss Majalamba. Are you in the meeting?
Hi, Mr. Bandi. She left.
Or she left?
Yes, I think she has connectivity issues.
Okay. Both the chairperson and the committee secretary appear to have connectivity issues. Okay.
Yes.
Thank you.
Hello.
Hello. Honorable members, good afternoon.
Good afternoon, Chair. Good afternoon.
Good
Yes.
afternoon, Chair.
Yes, I'm sorry to be logging in late. There was a challenge with the link. I see that quite a lot of us are linked in, 14 members who are already on. Welcome to this meeting. Uvuyo is still struggling. Uvuyo is struggling to reconnect, but
My phone is in full.
I have indicated to Vuyo that we'll start so long.
Honorable Chair.
Yes, Mama.
Honorable Chair. Yes.
I can see you, Mam Shlengo. Thank you very much. Yeah.
Ngiyathoba baba, ngiyathoba.
Yeah. Welcome to all our members. We have to start. Vuyo, Miss Machalamba is still struggling to log in again. She was in and now she's out, but we will start with the preliminaries. I would like to, for the first time we're meeting since we had the sad news of the passing on of Mama Kwahube, the mother to one of our honorable members. We also learned yesterday of the passing on of a grandmother to Honorable Chirwa. Maybe if we can just observe a moment of silence to honor the relatives of our honorable members. May the soul of the departed souls rest in peace. In peace. Thank you very much, honorable members. We have an agenda before us.
No agenda.
No agenda, ma'am?
No.
Okay, it was sent on our... Okay. If I could just reflect on it, the agenda is the welcome, and then we'll do the... Let me just see where I have it now. I have it on another platform now. We will welcome you members as we have done, and we will then go to God. to apologies, if there are any. I know definitely that there's going to be an apology from Honorable Kwahube, and there's also another apology from Honorable Chirwa. I'm not aware if Vuyo is able to tell us if there are any other apologies.
Chair, can I come in?
Yes, sir.
Chair, I'll be needing to drive from Acacia Park to Parliament because the sitting starts at 3 o'clock. So I'm not sure I need to leave here by 2. So I'm not sure if we'll be done by then. And if not, then I'd like your leave of to leave early session. Your permission. Thank you.
Thank you. Noted. Okay. We might record any other apologies later if Miss Machalamba joins us. Are you back now, Miss Machalamba? Yes, I can see.
Yes, Chair, I'm back.
Any other apologies that you want us to be aware of?
I'm sorry, Chair, I didn't hear the first part of the meeting because of the connection problems. I will just read all the apologies. I've received an apology from Ms. Kwahube. She's preparing a funeral for her mother. Ms. Chirwa is attending her grandmother's funeral. Ms. Sukers is attending the PC on social development meeting. Thank you, Chair. Mr. Van Staden won't be able to join the meeting due to connection challenges.
Okay. Thank you very much for those apologies that all noted. So we can then confirm the attendance of all other members other than those that have been apologized for. Thank you very much. Honorable members, we move to item number 4, consideration and adoption of the committee's report. We had last week a meeting where we were then able to listen to the report from the department, and we have since Ms. Machalamba compiled our report as a committee that we would like you to be engaged with. We know that you already do probably have a mandate from your political parties and yourself having looked at the report. We would then give this opportunity to members to comment about the report. I'll look into that. I don't know, this gadget is not user friendly to show hands. So I will then take hands, because if it was a Zoom, there's something that you show hands there. This one, it has also participants. If members can raise their hands, Mama, go to that gadget, Mam Shlengwa, press that thing that looks like 2 little people, and then if you raise your hand, then you go to the button, say raise a hand, so that I can recognize all members. So we are now going to allow members to comment, and then the second item will be to listen to, and hopefully Mr. Honorable Imam will still be around when we are listening to the experts about the impact of alcohol on health. So let us start with this one now, and I'll recognize hands from honorable members who would like to comment about the report, which has since been sent to us 2 days ago. Okay. I don't see hands raised, but then I will take. Let's do it then manually.
My computer's giving me a problem to raise hand, Chairperson.
Thank you, Chairperson. It's Lindy Wilson. I'd also like to comment on the report, please.
Okay.
I would also like to comment, please.
Honorable Wilson, you are number 1. Honorable Munyai, you are number 2. Honorable Imam Sheikh, you are number 3.
Honorable Shlengwa.
Mamu Shlengwa, you are number 4. Those are the hands so far that I've had. If there are any...
Honorable Kela, Chair.
Honorable Kela, you are number 5.
Honorable Jacobs, number 6.
Honorable Jacobs, you are number 6. And I'm left with Honorable Sokacha. Okay, and Hasina. But then we'll stop at that now, up to number 6. I will not come back to you, Corey, to ask you to come back again. You know your numbers. Number 6 is Honorable Kenny Jacobs, and number 1 is Honorable Wilson. Start, Honorable Wilson.
Thank you, Chairperson. 2 comments on the report, and one is on the recommendations, and the final one is on the conclusion. Under the recommendations, we had discussions about field hospitals and the lack thereof. I think that there must be a recommendation in this report that the shortage of field hospitals be addressed as a matter of urgency. There are several provinces in the country at the moment who've made no plans whatsoever for field hospitals, and as the COVID-19 pandemic surges, this needs to be addressed very, very urgently. Field hospitals that need to be obviously appropriately equipped with oxygen, ventilating machines, and all the required medication and facilities for COVID patients. I think that needs to be added to the recommendation. And finally, Chair, on the conclusion of that report, it states that the department should respond to recommendations in 3 months from the date of the report adopted by the House. Chair, with all due respect, we are in an absolute crisis at the moment. COVID has surged and will continue to do so for roughly the next 6 weeks. 3 months for recommendations to be reported on by this committee is way too long. Provinces have to have their budgets in by the end of July. I believe that by mid-August at the latest, we must have a report back on what has been done in terms of our recommendations in this report. 3 months is too long. Thank you, Chair.
Thank you very much. Recommendations that are making sense. Let us move to the next speaker.
Thank you very much, Comrade Chairperson. I move that we should adopt this report with all its recommendations, because it is not based on whims or emotions, but science. So this report has been really, it is aligned with the pronouncement of the president to suspend or ban alcohol during the COVID-19 because of its implication to overwhelm our hospital beds, ICU beds, which are preoccupied by trauma, and instead of the COVID-19 patients. We know with these indications, it comes with some challenges with respect to drunk people stabbing each other, shooting each other, leaving women, family disorganized, and also the advertisement of the alcohol should also be taken in. We should adhere to the recommendation in total, which means, in my view, therefore, let's use this 3 months target, right? If it pushes us to work further, where Honorable Wilson would have recommended, let it be adjusted as we move, because the leadership to commence with this report implementation, it will be of strategic importance for the country. In our view, it will help us in a great deal. I'm so excited, Chairperson, that this report is before the committee. I 100% support this report.
Honorable members, may I just remind you that this portfolio committee is live, and therefore we will so behave as if we are in a formal committee meeting. We will avoid, if you have a pressure to have a bite, please switch off your video, and then you can do that comfortably. But the video your video is being shown, whatever you do, wherever you are. Thank you very much. Third speaker. Is it Sheikh or Mama Sengwa? Sheikh, yes.
Okay, Sheikh, thank you very much, Chair. Let me come in there. Chair, one of my, I'm in support of the report table here, Chair. Just that I think on observations, I think we need to highlight the fact that the impact on reduction is going to have on the NHI, and we know that we've been looking for this universal health coverage, which many of our people do not have in this country. So just as an observation, but in terms of the recommendation, Chair, there's something that has come out, and it's recent actually. And I'd like the department to be able to find some solution or intervene in this, and that is that businesses and industry that is getting people tested positive, Chair. I'm getting repeated calls where there's a complaint from employees that the companies or business owners do not want to take the necessary measures. So I would like us to just recommend that the department puts in some minimal standards or requirements that these businesses and things must comply, particularly when anybody in these places tests positive, to protect the added or further transmission of the virus. And secondly and lastly, there are some people from civil society and the private sector that are assisting in trying to put up quarantine facilities at their own cost. And they're having difficulty in terms of certain communities that don't want to accept it. And I'd like to recommend that the Department of Health must intervene with the different structures or role players to ensure that this is implemented, because it only can benefit the people in our country. Thank you very much, Chair. And I support this, Chair.
Okay, thank you very much, Mama Sengwa.
Thank you very much, Chairperson. Let me greet all our honorable members. Mine is to accept the report and plead the speedily implementation of all the recommendations in the report. As I said, the IFP support report. Thank you.
Siyabonga, Mama. Thank you very much. Asiqhubekele phambili ke ngithi Honorable Ugela.
Thank you very much, Chairperson. Let me also welcome the report and also appreciate the report, Chair. I'm very happy, Chair, because it's going to address all the concerns and issues that were raised during our oversight visit in hospitals, particularly the issue of infrastructure spending that will assist provinces to prioritize suitable isolation and quarantine facilities for COVID-19, which is a good thing, Chair. And also the issue of making sure that at least psychologically health of health workers and also the department is going to make sure that at least we give them psychologically support, especially during this time, because some of them are also infected by this virus. So I'm very happy, Chairperson, with the recommendation from the portfolio committee. And as ANC, we really support the report as it is, and also wishing that if the department can also speed up the issue of implementation and also monitor all the provinces so that at least we take the same way as government of South Africa. But as ANC, we really support the report.
Order, Honorable Chair.
Yes, Honorable Munyai.
No, we are not in the ANC meeting. We are in a portfolio committee. I think the member might be coming from the ANC, but here we are under the portfolio committee radar. So therefore, she must say as portfolio committee, we support, not as the ANC here.
No, I don't think
Chairperson,
Hold on. Honorable Munyai, she is correct. If you are listening carefully, Umama Shlengwa to say, I support this. On behalf of the IFP, we give support to this report. There is nothing wrong about what Honorable Kela is saying. She is correct to express as a portfolio committee member, but also expressing what she knows is the mandate from her party. Thank you.
Thank you very much, Chair.
Continue, Honorable.
Thank you very much.
Thank you for correction.
Thank you very Chairperson, can I proceed?
Yes, please.
Thank you very much, Chairperson. And I'm very confident that as the ruling party in government, we'll make sure that we stand together and also we prioritize in health issues. And I'm very happy with all the recommendation, and also I support the report as it is. Thank you very much, Chair.
Thank you very much, Honorable Kenny Jacobs. But before Kenny, may I check if there's any other member that would like to come after Honorable Jacobs? Okay. Honorable Jacobs, you are the last one. Thank you.
Thank you, Chair.
Excuse me, Kenny. No, Chair, I lifted my hand. I'm in and out. I did indicate that I would like to speak.
we understand from the rural province. We'll give you a space after Honorable Jacobs.
Thank you, Chair.
Honorable Jacobs.
I seem to have lost the audio there, but I think I'm back on now. Just to say that much of the report obviously deals with what we are currently experiencing. The fact that we needed this adjusted budget, and that it does speak to, in almost every page, about the current challenge with regards to the COVID-19 pandemic. I would therefore want to say that we agree fully with the recommendations that the committee has made to the Minister of Health. I would just maybe want to say that if need be, I wouldn't mind if we would, for example, say the 3 months could be shortened in terms of the reply that we ought to be receiving with regards to the implementation. It would just assist us as the pandemic and the surge is still happening within our country, for us to be monitoring also where the process is going and where we need to be able to provide assistance with regards to our oversight. Thank you, Chair.
Honorable Dante.
Thank you very much, Chair. I would like to echo the sentiments of the colleagues of accepting the report and thanking the people who have prepared the report on behalf of the committee. We have got 6 recommendations, Chair, that are very concrete. And I agree that maybe there are those that we should ask the department to come back and report to us. I'm particularly interested in them coming to report to us on the infrastructure, because as we were doing the oversight, we noticed that we were still far behind in quarantine sites. So I agree, and I also would like to say the report should be adopted. Thank you very much, Chair.
Okay, thank you very much, honorable members. We have all expressed your on this, and I've listened to your comments, but may I therefore request now formally to know who is moving for the adoption of the report and who is seconding the adoption of the report. If I may just get that part. Thank you.
I am moving for adoption. Thank you, Chair.
Chairperson.
Honorable Jacobs is moving for the adoption of the
Chair.
report. Honorable Gela, who's calling? Is it Gela?
Thank you, Chair. I move for the adoption of the report as tabled before us today.
Honorable Gela, I take it that we are seconding it because Honorable Jacobs has moved for the adoption of the report. Therefore,
Yes, Yes, Chair, I'm seconding him for adopting the report.
Okay. Thank you very much, honorable members. We have now dealt with that part. May I then come to another part? I noticed a hand from what is the issue, Honorable Imam Sheikh?
Sorry to do that. I'm in support of the report, but I wanted to know what about amendments. Is it going to be supported with amendments like highlighting our concerns about the delay of the NSI as an observation and any of the recommendations, or are we adopting it as is tabled here in the report, the draft report?
Yeah, I would really recommend that we take the amendments suggested because they are actually taking us forward. Like Honorable Jacobs has seconded what Honorable Wilson was saying, to say 3 months, but why not bring it a bit earlier? The sooner the better for us, and therefore those recommendations up in the one. So let us actually then accept those. I was taking it that we take it that those recommendations are also accepted as to beef up the report. Thank you very much. Honorable members.
Thank you.
Honorable members, may I just raise another matter before we move to the next item? There is an issue that is actually taking place in the Eastern Cape about the scooters and the health service delivery support or no support thereof. We have resisted making comments from a level where we are, but I have been in touch and I continue to be in touch with the chairperson of the portfolio committee in the Eastern Cape Legislature on health. And I've requested that honorable member to say, look, we will not want to comment out of turn from the National Assembly. We would like you to appraise us of what are you doing there, what are the findings, what is the justification of the scooters, are they there, are they doing the work or what? So I want us to say we are not just quiet because we just choose not to. It's just that I was informed, I was waiting for the leader in the legislature in the Eastern Cape to appraise us about what is this issue about scooters in the Eastern Cape. Only then, honorable members, we may actually take it forward. There were some other members who were saying maybe let's get the MEC to come and brief us about that. So I've requested the MEC, the chairperson there to deal with that matter at the provincial level, but sometime come and serve to us in a distant future. I just thought I should raise that with the honorable members and leave it at that for now. Thank you, members. Miss Machalamba, have we been joined by the leadership that is going to brief us on alcohol and impact of alcohol on health?
No, Chair, they haven't joined yet. I requested them to log in around 22, 1, 12:30, but I can see they haven't logged in. So I'm trying to get hold of them to see what is happening.
Okay, honorable members, you can have a bit of a stretch, but I'm hopeful that we will be able to finish before to allow honorable Imam to travel to the main house. Maybe let's just get a bit of a stretch, and while we wait for them to log in. Thank you.
Have I been lost to the meeting? I can't hear anything.
I'm told we need to stretch, but I don't know how long.
Okay, thank you, Honorable Munyai.
We're waiting for the 7 up to log in, Kenny.
Okay, thank you very much.
Good day. Hi. Charles is about to start. Hi. Sorry, it's Glenda.
Yes, hello.
Hi, Glenda, welcome.
Hi. Charles is coming. I've just quickly called him. He's waiting to start because we were scheduled for 1, but he's on his way to start the call. He said he's going to dial in now.
Okay, Professor
Recalling.
Professor Gray, who has got the slides? Is it you or?
We sent. Charles has got. But we did send it through. Charles sent it through this morning, but I can get them and load them for so long.
Yes, no, you did send them. I'm just checking who's going to be loading them the other side.
Okay. Did you find them? Buya's got them as well.
Okay. Honorable members, while we are dealing with the logistics of putting the slides that some of us have already got, so that she can take us through, because there's a media that has been invited, they may not be able to have access to those slides, so we still want those slides beamed up there. And let me then take this opportunity to welcome Professor Glenda Gray and her team that she will introduce. We are very grateful about this opportunity because I call you a group of South Africans who are very much in tune with the happenings of the society. You're not actually doing research work that is out there, maybe in faraway country. You are bringing to us something that is relevant from your research. It's some of us, therefore, who are politicians who must be educated into actually supporting and formulating appropriate policies based on the research work. I'm looking forward to your presentation, and I hope that it will enrich our thinking and will make us to understand what we should do if there is any need of a legislative amendment to the things as they currently stand. With those words, I welcome you, Professor Gray, and the team that you are part of. I see that your slides are already showing there. Maybe let me give you this space to then comment, introduce, and then start with the presentation. Thank you very much.
Yet, because they were busy, they were waiting for one, but I have.
Am I on, Glenda?
Oh, cool. Okay, that's great. So I think the most important thing that I need to say is that the Medical Research Council's job is to fund and conduct research that will change the lives of South Africans, and that's our mandate. And so whatever we do, the express aim is to make sure that our research findings improve the lives of South Africans. And we divide our research into two groups. One that addresses the social determinants of health, and in that area we deal with issues of mental health, alcohol, drug, and other related tobacco research. We deal with gender-based violence, and we deal with a maternal and child health. So all issues that are aimed to try and improve health through addressing social determinants of health, and trying to find ways, interventions that can alleviate ill health and mortality in those domains. We also are interested in other interventions, public health interventions, as well as basic science and drug discovery, vaccine research, as well as precision medicine and genetic and cancer-based research. So we try and focus all our research on the 10 most causes of mortality in South Africa, and try and make sure that we address everything. So if you don't address mental health, you're never going to address issues of alcoholism and depression. If you don't address public health issues, you can never address issues around improving the health system. So all our research, even though some of it may seem very like basic science, like doing whole genome sequencing, it's all based to better understand the South African from every element. It's the ecological, the genetic, and the environmental, and how South Africans can improve their health, not only medically based, but also sociologically based as well. So that's just the background that we do. So we always try and make sure our research is focused on South Africa and South African response to the social determinants of health and morbidity and mortality. So I've got one of the most famous scientists, Charles Perry, who's spent most of his adult life at the MRC, and has been dedicated to looking at issues of alcohol, tobacco, and other drugs. And so he is a world expert on this matter. And certainly the work that we do in South Africa is actually a driver of policy at a national and international level. So we're very privileged to have Charles working with us, and he is here, and he's much more eloquent than me, and much more well versed in this subject as well. Charles.
Thank you very much. Should I present my slides, or are they on the screen from your side?
Charles, are there any more else? Is there any others? Is it just you and I?
I will do the introductions even if they come on later. So okay, thanks. Cool. Can I present them? And then how do I get it to full screen? Sorry to, it's on your side. So I'm just trying to see how to get them to full screen.
I think Vuya's got them.
Yes, Vuya's got them. I wonder if she can just do them for me if I just say next slide.
Yeah.
Is that possible? Vuya? Okay, I can't see the slides though, so that would also
be. If you want to share, I did see them a while back, but they seem to have gone.
I can share my own if you like.
Maybe share your own. Yeah, share your own.
I'm on the screen now. Either I have them. Just give me 1 second, then I'll be right with you. Okay, we're in business. I'm going to slideshow on the current slide. and go from there. I'm just trying to, sorry, to see how we can present them on the screen. Okay, I'm going to, sorry, the reason I've got two screens here. Okay, I can do them for you. And I'll do the introductions. Okay, I'm just going to do present slide and then we're away. Can you see them now in front of you?
Yes, thank you. And we
Perfect.
all have copies of the slides.
Okay,
Yes,
thank you.
Yeah.
They have changed slightly. Okay, I'm going to start. I believe I've got 25 to 30 minutes, and I'll be moving quite quickly through some of the initial slides. You've seen the title is The Impact of Alcohol on Health Services in South Africa. Thank you for that introduction. We appreciate the opportunity to speak with you today. I'm going to be talking very briefly about the drinking context in South Africa, which you've seen the slides, so I don't need to go through them in too much detail. Then the modeling of the effect of a temporary ban on liquor sales in level 3. And then also what's really important is alternatives to a ban on liquor sales to reduce the burden on the healthcare system, especially trauma admissions. And then thinking about a new normal with regard to alcohol. The team that developed the model for level 3 included 2 members of the Ministerial Advisory Committee on Health, who you may well know, Professor Yunus Moosa and Professor Simon Nematundani. And then the other members of the team, I've highlighted the 3 members of the Medical Research Council as myself, Richard Matsopoulos, who's the picture down below in the middle. And then at the bottom is Danella Besada, who's going to be joining us, who's a health economist. And then we also had 2 trauma doctors, Professor Steve Moeng and Professor Andrew Nicol. And then we had Professor Mzungile Ndikika from the Nelson Mandela Academic Hospital, and then Maurice Smithers from the Southern African Alcohol Policy Alliance. That was the team of 9 of us representing alcohol epidemiology, health economics, particularly trauma doctors, and so on. So the drinking context in South Africa, looking at use and harms, and this has become very topical now with what's been happening during the lockdown phases. The issue is really that South Africa, a very small proportion of the population drink, only about 31% of adults, which is substantially less than the world average of 43%, but similar to the AFRO average of 32%. Where we start to differ is when we look at the amount of alcohol drunk per drinker per day in grams of absolute alcohol. The average for us is 65 grams per drinker per day, which is between 5 and 6 drinks per drinker per day. And I'm not drinking in that amount, so someone's drinking a lot more than that. The other issue of importance is heavy episodic drinking. And I mean, that's linked to problems like trauma-related incidents. 59% of our drinkers engage in binge drinking at least once a month. And this is 20 percentage points higher than the AFRO average and 9 percentage points higher than the world average. So we have a problem not with the numbers of people who drink, but with the amount that those of us who do drink. The next slide shows the deaths, alcohol-related deaths. Oops, sorry, can you still see the slide? Yep. Showing between 6 and 8% of all deaths in South Africa can be attributed to alcohol. That's 171 per day, or 62,300 per year. So we're in the second highest category there. Again, this slide comes from one of my PhD students showing how it differentiates the deaths from alcohol by gender. And you'll see the bars are much bigger on the right for males, and particularly for those who are at lower SES levels. And when we look at men in particular, you'll see high levels of alcohol-related infectious disease deaths, and the yellow bars are the alcohol-related trauma, which leads to death. So that's a huge problem we face in South Africa. The other area is people don't always die from alcohol. Sometimes they're injured and they live with or have other health problems and they live with them for many years. So the other concept is disability adjusted life years lost, which is the years of life lost because you die early or because you live with a disability. And this is looking at the alcohol relatedness of that. So between 5.5 and 6.6% of all the years lost, disability adjusted life years lost in South Africa can be attributed just to alcohol. Now we get to the modeling. I'm going to slow down a little bit here. What would be the effect of modeling a temporary ban on liquor sales in level 3? So the graph on the left shows us the COVID-19 confirmed cumulative cases over a time period up to around the 13th of July. And we've now exceeded 250,000, a 250,000, and that's probably an underestimate because we don't always know everybody who's confirmed. And those lines show the various levels of lockdown. And I've got on the right, I actually show the phases of the lockdown when we look at alcohol. So to the left of the first bar is what I call the pre-lockdown period, normal restrictions on alcohol. Then the next period on the right is from the 19th to the 26th of March, which was what we call lockdown light, where there was really mostly restrictions on when alcohol could be sold. And you can see those yourselves there. Then we had the hard lockdown in levels 4 and 5, which was a complete ban on the sale of liquor during the 66-day lockdown. And also there were also other restrictions on the transportation of liquor, limitations on movement and work, etc. And there was some curfew which came in level 4. So we need to bear that in mind when we look at what happened to alcohol. Then level 3, 1st of June, suddenly alcohol could be sold again from both on and off consumption outlets, but only for off sales and only between 9 a.m. and 5 p.m. on a Monday to Friday. And there was obviously much more opening up of work and movement in the level we're in now. And then what I call level 3B, which is from the president's, which is really from Monday this week, where the additional measures included the sale, limitations, or the ban on the sale, dispensing and distribution of liquor, and the transportation of liquor is prohibited except for export. And in addition, we have a curfew, which also is relevant when we're talking about alcohol, because people now need to be home before 9 o'clock, ideally. The other points to make down, when we look at the alcohol effect, during the period which I call lockdown light, which you can see on the graph on the left, LL, which was from the which was before the hard lockdown. Data for the weekend of the 21st and 22nd of March showed a 25% to 50% drop in transport emergencies dealt with by the ER24's contact center. That was really just starting to show us the effect of what a sort of a tightening of alcohol hours would even have. That even had an effect on the transportation of people to hospital for emergencies. Then in levels 4 and 5, we saw a 60 to 70% reduction in hospital visits and admissions to trauma centers. And then in level 3, we've noticed a surge in trauma-related hospital visits. And anecdotally, that's been attributed to the easing of restrictions related to the sale and distribution of alcohol. And calls have been made to by certain premiers in the Eastern Cape, and I think the Gauteng, for example, to reimpose alcohol restrictions with claims that this would stem trauma-related hospital visits, thereby freeing up health services, staff, and wards for the care of COVID-19 patients. The questions that we were asked by the MAC, a subcommittee of the MAC last Monday, were essentially these two. What would be the effect of reimposing a ban on liquor sales during level 3 lockdown on trauma-related hospital visits and admissions? And secondly, what would be the effect of placing tighter restrictions on alcohol access as opposed to a ban on liquor sales in terms of reducing the burden on public healthcare system and trauma admissions? That was one that we added. We felt we needed to also look at that. We were also asked questions about at which level would it be prudent to administer restrictions on alcohol at a local level, provincial or national level, and so on. The team spent Monday the 6th last week and the morning of the 7th addressing these questions for the MAC, and we presented it in the afternoon on Tuesday the 7th. And then the broader MAC considered them on the next day, on the Wednesday, and then I believe on Thursday last week, it went to the NCCC. And I've done a little bit of modeling since then, which I'll bring in I did it with Richard and Donella, who I mentioned earlier.
Perry,
Yes.
Can you just say your MAC in full once, and your entity in full once, because not all of us may be aware what is MAC. Say it once and then that's fine.
Sure. The MAC, we're talking about the Health Ministerial Advisory Committee, and that's chaired by Professor Slim Abdul Karim. And we were tasked by a subcommittee, in fact, by Professor Karim, and it went through to Professor Yunus Moosa, and then he compiled the subcommittee to work on it. And then it went to the full MAC, which we only presented to the subcommittee. It was taken up by the full Ministerial Advisory Committee on the Tuesday, and then went to the National Coronavirus Command Council, I believe, last Thursday. So this is the model in a sense, and I want to take you through it briefly. This is and then it has another stage following on to look at the impact of this bed saving or admission saving on hospital beds and costs and things like that. So initially in level 5, myself and colleagues at University of Cape Town trauma unit, Andy Nicol and Professor Navsaria, and also Richard Matsopoulos from the MRC, we came up with a number of about 1.5 million trauma admissions. In fact, this is data from Richard Matsopoulos in '99. And then we had to increase that by the population growth for adults aged 15 and over using Stats South African numbers. So we got a figure of 2.2 million trauma presentations each year across approximately 350 to 400 public, secondary, and tertiary hospitals. So that's the number we're working with. What it works out, if you divide that by the 52 weeks a year, you get 42,700 presentations to public, secondary, and tertiary hospitals each week. I know it's a staggering number, but there are almost 400 of these hospitals. So that's the number we worked with. Then the next point we did, we had a whole lot of debates looking at available data and came up with the idea that now in level 3, we're only seeing 80% of what was the pre-lockdown period. So there's only about 34,000 presentations to trauma hospitals each week across South Africa. And the next task was to look at the proportion of those that were alcohol related. In level 5, we'd looked at previous research done over many years and come up with a figure of, very conservative figure of 40% of all trauma admissions are alcohol related. We've now revised that based on data that we had from particularly Groote Hospital, Charlotte Macnege Hospital, and Chris Baragwanath Hospital, and so on, and looking at a figure of about 50% now. That's what the trauma doctors are telling us. And we also spoke to people from the Eastern Cape and looked at KZN data. So 50% of 34,000, which is 80% of the previous amount coming to trauma units, means there are about 17,000 alcohol-related trauma presentations each week. The task we really had to look at was how much of those could we reduce through, for example, a ban on liquor sales. And this was involved a lot of debate, looking at data that the people from the Ministerial Advisory Committee were able to access from different provinces. I think the only province we didn't look at was the Northern Cape, and basically discussing amongst ourselves. And we came up with the notion that it's not going to be all at once. In the first week of a ban on liquor sales, there's still a lot of alcohol around there. So the consensus figure was about a 20% reduction in alcohol-related trauma admissions in the first week, increasing over several weeks to a maximum of about 40%. You're never going to get all of it to go away. So we come up with a period of over 8 weeks. It'll be 20% in the first week, 30% reduction in the second week, 40% in the third, and then 40% thereafter. If you look at an 8-week period, none of us know how long this ban's going to go on for. Over 8 weeks, the estimation is it'll come to just under 50,000 trauma presentations that could potentially be taken out of the system through a ban on liquor sales. That is only 18% of all trauma admissions, or 36% of alcohol-related trauma. But even that, we believe, will make an impact. And if I go to the next slide, I'll take you through this. The next 2 slides give a bit more information. The implications of this we wanted to make clear as well is that trauma patients who present to a healthcare facility and don't require admission, but they still have to get patched up and sent out, that still contributes to overcrowding and therefore to increasing the risk of transmission of the virus between patients and staff in the ER. And even trauma patients who are not COVID positive may become COVID positive because they are exposed to other people in the medical facility. And there's a good clip from Professor Karim explaining that further, which has been in the media. Trauma patients requiring surgery consume a lot of resources such as theatre time and skilled staff. And for example, a surgery typically involves six staff members, a couple of surgeons, nurses, and so on. And they can potentially be deployed to other areas of need in the hospital. So they take up a lot of resources. And polytrauma patients who have multiple wounds frequently require prolonged hospitalization and extended rehabilitation, often exceeding 4 weeks. So I'm going to wrap this little part up shortly. Using data from level 3 from 5 Western Cape hospitals to indicate the spread of trauma presentations across different injury types, because we need to put some data into the model. We know our estimate is about just under 50,000, but how are they going to present in terms of knife wounds, gunshot wounds, stab wounds, blunt wounds, motor vehicle injuries, alcohol poisoning, self-harm, burns, falls, and so on. We had to take the data from somewhere, and the best data we could in terms of the spread of trauma injuries was the Western Cape data, which is available, in fact, from January right through to the end of June. So feeding that data into the 50,000 across the hospitals around the country would come to 124,000 less days spent in general wards and 46,000 less days of ICU bed occupancy, or a saving of 1.3 billion rands. This is using the mosaic model developed by Sue Clary et al. At the University of Cape Town and colleagues at the MRC, including Danella Beseda, who's on the call. And that 1.3 wouldn't all be available because some of those costs are related to having the hospital, paying hospital staff, and so on. But between 25 and 27% are consumable costs relating to pharmaceuticals, goods and services, and other consumables. But what we did was we fed that 1.3 billion into the model, the mosaic model, which is available online if anybody wants to see. And this would enable the treatment of about 17,800 COVID-19 patients in general wards, or just under 13,000 in ICU wards, or some combination of that. So that's the kind of saving over 8 weeks we'd get from the just under 50,000 alcohol-related trauma presentations that we believe a ban on liquor sales could achieve. The other thing, I'm looking at the time here, please tell me if there's a problem with time, is we looked at the alternatives to a ban on liquor sales to reduce the burden on the healthcare system, especially trauma admissions. And these, on the left-hand side and the right-hand side of this table, you can see some of the areas in which we thought the government should be thinking about imposing further restrictions. So, for example, around limiting availability, we could have gone from 4 days a week to 3 days a week. We could have stopped the off sales by on-consumption outlets and allowed only those with an off-sales license to sell alcohol. We could have perhaps persuaded the industry to reduce their manufacturing capacity, particularly of beer. They produce SA Breweries, for example, produces 3.1 billion liters per year. We could have imposed limits on the quantities that people could take away with them to stop the moving of bucky loads full of beer and then reselling. We could have moved ahead with the plan to reduce the blood alcohol level to drivers to get the message out. We don't want any drinking and driving during level 3. Packaging, we could have also moved ahead with banning advertising except at point of sale. And that was a provision in the 2013 Control of Marketing of Alcoholic Beverages Act, which was approved by Cabinet but never went any further. Maybe that sort of thing could be implemented during level 3, just to take out the sort of marketing of alcohol. We don't want to encourage people to drink. We also talked about the possibility of implementing tracking systems so we can track products to track where it is being illegally sold. and then pushing some options for treatment, because there are many people who, now that we have a ban on liquor sales, if they can't get alcohol, will be struggling with the how to deal with dependence and withdrawal. So those were discussed, but the feeling was to be much harder to model those. It's almost impossible, and certainly in the time available, to model the effect of those in trauma admissions. And these are, we would like to say, are following the evidence-based strategies by the WHO, most of them. In contrast with a ban on alcohol sales, obviously, these are much more challenging to implement and likely to have a lesser impact, even if they're used in combination, rather than a hard ban on liquor sales. I personally think we should have looked at implementing some of these at the start of level 3, rather than right now when there's starting to be pressure on hospital beds, particularly in KZN, the Eastern Cape, and Gauteng. But strategically, we did push to the MAC that it might be useful to consider adopting the lesser approach of this basket of interventions initially, and seeing how it goes for a few weeks before going ahead with a ban, if required, in order to prevent pushback from the public and the liquor industry and associated businesses. It might also make it easier to defend legal challenges, because then the government could say they've initiated less intrusive strategies first. So we presented both to the Ministerial Advisory Committee. I think it's very important right now that we talk about what could a new normal look like with regard to alcohol. The reason for this is we're not going to have a ban on liquor sales forever. It will come to an end, possibly in 8 weeks, 10 weeks, something like that. I don't know, it's a political decision. And we need to also be ready so that when alcohol is re-permitted for sale in the next phase, that we don't have the challenging situation we had at the start of level 3. We're more prepared, we have more restrictions in place. I'm just showing this slide here because I don't have space on my later slides. It's looking at taxation. That's something to be looked at, perhaps not in the short term, but in the longer term. What it shows is the level of taxation on beer and spirits has dropped over time below that in real terms in relation to tobacco. So we used to tax alcohol more than cigarettes, but now we're taxing cigarettes more than alcohol. And maybe that's an area for looking at in terms of future interventions. How do we prepare for a new normal, recognizing the weaknesses in our regulatory environment? This, as I say, also has implications for what we should be doing now to plan for what we should do when the ban on liquor sales is lifted. I think that's happened. I doubt it's going to be turned around, but we should be talking about what are we going to do after it's relaxed. We need to talk about, and here are some of the strategies, revisiting the hours for on and off consumption. This is now also in the long term, even after the lockdown ends. We need to take into account outlet densities. That's the number of outlets in an area in granting liquor licenses. Some areas, potentially, particularly residential areas, may have too many outlets, and that causes problems. We want to reduce the situation where we ever have to have another ban on liquor sales again. I don't think that's something that we should be thinking about too lightly. We also need to look at something called risk-based licensing for setting licensing fees. So if an outlet has been more problematic in the past, then the cost of granting them a license goes up. The Liquor Amendment Bill of which 2017, which also seems to be stuck, talked about raising the drinking age to 21. That's with Department of Trade and Industry. I think we need to look at perhaps first raising the drinking age to 19 years, which is when people are still in school often. They're finishing school at 18, so perhaps raise it by 1 year and see how that goes. And we must do a better job of checking for identification when people buy alcohol. I've certainly been checked in the United States. We also need to look at the issue of delivery of liquor by groups like Uber Eats and things like that. It's less risky. You really should have alcohol delivered by a company which has a stake, has a liquor license, so that if they deliver to underage youth, that there can be consequences. Because if you have a driver who's only temporarily employed by Uber Eats, there's no consequences really for them delivering to underage youth. In the long term, we need to look at the issue of alternate income generation for home-based shebeens. I think we have too many liquor outlets, and that's contributing. Many of them are unlicensed to the problem of the drinking that I talked about at the earlier slides. The Cabinet approved the decision to look at reducing the blood alcohol level to 0. I think we should perhaps look at 0.02 grams of absolute alcohol per 100 milliliters of blood. That would at least allow people to have medications. I think we should move quickly on that. We need to automatically test blood alcohol after serious motor vehicle collisions. And we need to look at better enforcement of local public drinking bylaws. In terms of price, alcohol is very cheap in South Africa. And I've been looking at pricing. Much of the alcohol is sold between 4 and 6 rand per standard drink. And that's 12 grams of absolute alcohol, or 15 milliliters of absolute alcohol. That's incredibly cheap. Many other countries around the world are looking at minimum unit pricing. Maybe we should raise it to 8 rand minimum or 10 rand minimum per unit of alcohol. We also have the anomalous situation where spirits are taxed at a higher rate than wine and beer for the same amount of absolute alcohol. I think we need to look at rationalizing that and perhaps consider increasing taxation. Advertising, we have too free advertising of lifestyle. We have people marked saying that if you drink, you'll gain social and financial success. If you open this bottle, you'll have sunshine in a bottle. And we need to really only allow advertising which really talks about the true, real characteristics of the product. Where does the wine come from? How long it's grown? What the cultivar is, for example. And perhaps we should only allow alcohol advertising at points of sale so people can decide which products to purchase. We also have a problem, which we've shown, with people buying alcohol in containers larger than average size containers. This is research done by the Medical Research Council. So people buying in these like 750 ml bottles of beer or 1 liter containers. And I've got a picture up there of the Carling Black Label beer bottle with the byline made to share. People also buying wine in restaurants in larger glasses. I think we should look at that issue. Improved labeling of alcohol products is getting a lot of attention globally. We need to look at putting the standard drinks so people know how many drinks they buy. When they buy a 500 ml can of beer, that they're drinking 2 standard drinks or whatever it is. Calories should be clearly marked. As I talked about, the tracking system, which Russia did very successfully, so that you can see where alcohol is manufactured and how it moves down the supply chain. So if you get illegal supplies, you'll know you know where it came from. And then also we need to be a compassionate country and look at the treatment needs and provide brief treatment, medically assisted treatment for people struggling. And at this time, even during level 5, provide information about where people can go for help and provide drugs like diazepam, vitamin B12, or naltrexone for people who are really struggling a lot with dependence. My concluding thoughts, my last slides. Thanks for listening patiently. I think we need it, and this is, I feel passionately about it. I've been saying this for 25 plus years. I have a document I sent to the Department of Health when Minister Dlamini Zuma was the minister in 1996. We need a clear multi-sectoral national plan. Our DTI national liquor policy is not strong enough and comprehensive enough. We also need competent, empowered leadership to drive the plan. We need to ensure that a plan is properly funded. We also need to be very aware of conflicts of interest when engaging with the industry. They are now coming on board trying to say that they want to be involved in reducing alcohol-related harm at this very late stage. In fact, I saw an email yesterday. But we need to understand that their primary business is manufacturing liquor, making profits for shareholders. So I think the government needs to engage with industry, but it doesn't need to partner with industry. We need good monitoring and evaluation mechanisms so that we can monitor how well we're doing and tweak the system. We found that our monitoring of trauma admissions, and particularly alcohol-related trauma, is not as good as it should be. And I think that's a gap. Many countries collect better data than us, and it should all be available at the click of a finger nowadays. We need good reporting mechanisms. I'd like once a year. Ideally, the Minister of Health would stand up and say, what's been achieved from implementing a national alcohol strategy? We should consider funding a health promotion foundation. And there's an article that appeared in the South African Medical Journal, I think 2014, on that to assist the government in rolling out a national alcohol strategy. Other countries have done this quite successfully, like Thailand with the Thai Health Promotion Foundation, and also in Australia with money from alcohol, sugar, and cigarette taxes. And I think the starting point to move ahead is with various pieces of stalled legislation. We have the stalled Control of Marketing of Alcoholic Beverages Bill of 2013. We have the Department of Transport's Drink Driving Amendment Bill of 2013, which was finally approved by Cabinet in March this year. We have the Department of Trade and Industry Liquor Amendment Bill of 2017, which doesn't seem to be going anywhere. And it's not only in the national level. At the Western Cape, we have the Alcohol Harm Reduction White Paper, and really that's, although it's partly being implemented, it really hasn't been properly approved by the provincial legislature. Let me end with that, and yeah, thank you very much for listening.
Okay, thank you very much, Honorable Professor and the team. We would now want to engage with this report. Honorable members, we must actually indicate that in our lifetime, we have actually impacted on these issues. We just cannot ignore such an important piece of work that has been done that has a huge bearing on how we actually carry ourselves. There's an important opening remarks by Professor Glenda Gray that says we try and do research that is relevant to the lives of the country, of the nation where we are. And there's one very important too. Number two, we have listened to these presentations and they are showing us before or after COVID, they are showing us with and without lockdown. And you just have to go to trauma centers in hospitals and see. But what this report is not showing, of course, they were probably not expected to do that, is that some of the people are drunk and they are driving, even before you get them into a casualty bed, which, by the way, is the most expensive bed you can ever find in any hospital. You have to send a very expensive vehicle, sometimes a helicopter, to go and pick up a drunk person. You pick up a person who's drunk on the other side of the cliff because you are trying to save lives. That cost has not even been put in here. So we can't leave it to people who drink the way they do. And I'm glad to hear a report that says it's not every South African who drink, but those who happen to drink, they just drink too much. I was going to start giving you, honorable members, start with Honorable Imam Sheikh because he will have to leave sometime before 2. Can I get the other hands from honorable members?
Honorable Jacobs.
Honorable Jacobs, you are number 2.
Lindy Wilson.
Honorable Wilson, you are number 3.
Honorable Sengwa.
Mama Sengwa, you are 4 again today, 4.
Honorable Hendricks.
Honorable Hendricks, number 5. Honorable Janchi, you are number 6. Is she still here? Oh, yeah. Any other call? Any other member?
Honorable Kela, number 7.
Honorable Kela, number 7.
Honorable Chirizimnyai, number 8.
Number 8, Honorable Munyai. Let us then start.
Thank you very much, Chair, and thank you very much to the SMRC for that presentation. Indeed, it was long overdue, I must admit. And I think let me start off on the premise by saying that is why almost most religions actually forbid you from taking alcohol. Islam, Buddhism, even many parts of Christianity forbid you. And those that do, always expressing caution on excessive drinking, use of alcohol. Even Hinduism has the same views in terms of that. So I think, we have it. Now, let me just start off by asking SMRC, and I think let me say this, that if there's anybody that can help this cause of dealing with this problem, is SMRC, particularly with your research. Have you done any research into the problem of alcohol fetal syndrome or fetal alcohol syndrome? That's what they call it. And remember, it comes from the original DOC system where people used to be paid with alcohol. And I must agree with you when you talk about conflict of interest, where we talk about the loss of revenue as a result of the putting restrictions on the sale of alcohol. But simultaneously, we don't measure it with what it is costing you as the impact to the economy when you allow alcohol, and that is as a result of accidents, gender-based violence, and everything else that goes with the consumption of alcohol. Now, I also want to know, and this is my observation on the ground, there appears to be, and I see you talk about 59%, I think, South Africa in terms of heavy drinking. And I think what we must emphasize that 70.8% is men. But more importantly, I find time and time again, the youth, the younger generation, particularly those are now entering tertiary institutions and things, that is where it seems to start. And I'd like you to tell us whether you're doing any research into particularly the high volumes of intake of alcohol, particularly with age groups, because I think that would help. And I agree with you, the other issue is the availability of alcohol with taverns and things. But remember, with all the stats we have in the country, great percentage of the crimes committed are late hours of the night, early hours of the morning, linked to taverns and these illegal bars and legal bars and things like that. So I'd like you to tell us what do you think could be basically done in terms of that. And yes, I think what we need, the issue of price increase, I want you to tell us, don't you think there's a danger there? The more you increase the price, the higher the level of poverty will increase, because people are going to buy it like they're doing with cigarettes at the moment. I've got many others, but I think we'll engage at some of the time. Let me give the others opportunity because I have to run back to Parliament. Thank you.
The next one, Honorable, I think Jacobs. Yeah.
Yes, thank you, Chairperson, and thank you very much, Prof. Parry, for the presentation, and the MRC for the great work you have done. We have noted that the decision that was taken to ban liquor again has a lot to do with your research, and we know it's very good research, and we have followed it up before, and many of us have been studying it, etc. And thanks for your contribution, therefore, through your research to assisting South Africa to save our people. Now, as government is saying saving lives and saving livelihoods, we understand that there has to be a relationship between the production and the sale and the use of alcohol. So what we understand is that 30% of people in South Africa who use or abuse alcohol, there are only 30% of people who are then the cause of us having a net deficit of 6 or 1.6 billion rand annually in terms of the gains that we get from the profit made from the sale of alcohol and the expenditure on the part of the on the healthcare of those who then abuse this and then somehow land up into hospital. That is very marked. Therefore, the question must be asked, is there really any gain to be had from the production and the sale of alcohol in the end, if that is the net effect? Therefore, it brings me to the point of marketing of alcohol. When you raised that you were looking at 2 points here, one was the ban, which is now the ban in place at this point in time, and the other challenge of maybe having other forms of restriction. You raised something about maybe there should have been restriction with regards to the marketing of alcohol and it only being shown or advertised at the point of sale. And the question would still be, what would be the efficacy of this as related to the drinking behavior and the habits of South Africans? We have a serious challenge with our people's behavior and the habit of the use of alcohol, as we spoke about in terms of the 30% of people of South Africa who use alcohol. And then the next one, point I want to raise is what happens after this now? What happens after the ban now? So we need to really focus ourselves on what kind of restrictions would be put in place. And you mentioned quite a few there, and those are very relevant ones. I just want to raise two. When one drives down the road, you see people now sitting in public in little groups with chairs on the side road having the alcohol. It's a strange, ugly, very ugly thing that we see in South Africa. I am wondering what is the effect on our tourism sector with regards to this. The second one is that people now carry their alcohol and the beers in their hands without packaging. We understand the effect of plastic on the environment, but we should maybe go back to having it as part a rule that and a law that all alcohol should be packaged and from the liquor outlet, put in a bag into a container, so that people don't walk about with 3-5 bottles of beer in the hands or crates of alcohol in the being carried by 2 persons. That is really not on. That speaks to the behavior and the attitude of our South Africans. So in terms of the new normal, thank you very, very much for that slide. The last one is in terms of the alcohol producers. We definitely need to put in some rules with regards to the contribution that alcohol producers and should be paying towards the costs of healthcare of those who find themselves within our facilities because of the use of alcohol. Thank you.
Members, let us try and make sure by 2 we log out to allow members who want to travel and start the other meetings in the legislature, please. Next one, Honorable Wilson.
Thank you, Chairperson, and thank you, Professor Barry, for the presentation. I'd like to make a couple of comments on it. The first issue I want to raise is we spent 110 days in lockdown, and the initial part of this lockdown, particularly the hard lockdown, was in order for the health systems to prepare themselves for the surge of the COVID-19 pandemic, which is what we knew was going to happen, and we knew we were going to see the surge, which we are currently in. My question to you, Professor, then is, if we was locked down for 110 days to prepare the health system, surely what one does is take the current health system and improve on it. So in other words, this is what we had before. These were our trauma cases. These were our pregnancies. These were our HIV, AIDS. These were everything we had. We now need to increase our capacity to keep that in place, but increase our capacity to deal with COVID cases. And I think this is very apparent that this has actually not been done, that we've actually fallen severely short. In terms of the Bill of Rights, a person has the right to make, or the freedom of choice to make decisions about their health. And we've had these discussions before, amongst these are abortion. This will include smoking and drinking. So these people have a constitutional right. Whether we agree with it or not is not the issue. We're talking about constitutional rights of people in this country. Now, by banning the liquor, are we not standing on the constitutional rights of people to make decisions like that for themselves? And I'm not saying people are not irresponsible. They certainly are, but you can't make a whole lot of people pay for the irresponsibility of a few. When you treat people like children, they start to behave like children. Okay, now we know that smokers have not stopped smoking. In actual fact, what they have done is they are buying cheaper brands, they're buying black market cigarettes with higher nicotine, higher tar, heaven knows what else in them, but they continue to smoke. And I think the same happens with drinkers. We are already seeing, and we've had dozens just today, of the amount of bottle stores that have been broken into and alcohol stolen in huge numbers, absolutely huge numbers. So the drinkers are determined not to stop drinking. What they are doing is those criminals, what they are doing, number one, is first of all put those businesses at risk that they've stolen from. Secondly, they are selling that alcohol at inflated prices to people who are now possibly using grants to pay for that alcohol. And we know this happens. It's common knowledge. Now we're going to face another crisis in that we now have starving children. We have people going hungry. We have, a myriad of other situations arising out of that. Alternatively, they go and make their own alcohol. And this is happening all over the country. I mean, I get a dozen recipes a day. Try this, try this, try this. Not because I'm a drinker, because people are sharing information. They are now drinking stuff that they shouldn't be, with mixtures that they shouldn't be. People are now dying as a result of that too. So there's a whole lot of implications involved in this ban. Of obviously also the huge risk to the economy. And I think, and perhaps Professor Barry, you can clarify this for me, the use of alcohol, and particularly in countries which are poor and have a lot of unemployed people, are generally higher, possibly because they have nothing else to do, and drowning one's sorrows is a way out. And finally, Professor Barry, I liked your concluding thoughts. I really did. But what I wanted to add in there is you mentioned that we need a competent leadership. By heavens, do we ever. At this moment in time, we've got 0 beds, rehabilitation beds for 0.1% of addicted people, whether it be drugs or whether it be alcohol. We are not going to ever manage to bring our numbers down or help these people if there is no way where they can go, nowhere to go to. We are short of social workers, we are short of rehabilitation beds, we are short of funding in the sector, and I really think it needs to be addressed too. Thank you very much.
Next, Mam Tengwa.
Thank you very much, Chair. Let me welcome the report and greet all the group there. Mine is very short. What one observes in the impact of the alcohol in the country, it has created a gender-based violence. When one is drunk, it has created a gender-based violence. Children, the families fall apart. There is a high rate of accidents that make our hospital very full. Instead of admitting the COVID-19 pandemic, they now admit these people who are highly drunk, who are getting involved in an accident. Trauma alone, that is cause a very much differences in the families. One person who is having trauma, it causes a havoc in the families as well as the community because of this trauma. And then instead of addressing the trauma, go and drink and then doing havoc things. What is the value of alcohol in the country? Because if you look at the alcohol, it shapes our country into the amoeba shape. What is your recommendation in terms of alcohol is concerned? Because we want our country to be on a safe side as far as COVID-19 are concerned. We really need a strong policy or recommendation in this pandemic of alcohol, because alcohol now is becoming a ruling country of the alcohol. Alcohol is becoming 100%. I don't know how to put, but alcohol is now doing everything. It is wrong. Lobu tshwala obuphuzwayo buphuzwa ngisho nazi ingane manje. Kuqala ngibone ngo-1960 there were old people who were drinking in the 1960, and there was a specific percentage that it must be to the people. But now it's open. Let us have a strong policy or recommendation as far as alcohol are concerned. Thank you.
So, number 5, Umama Uhlengwa is saying people are drinking alcohol now to show off. young as they are there to show off that I'm around and it's my right to drink as much as I can. It doesn't matter how much I'm going to affect the health system of the country and the resources. You just give me space to drink as much as I like. That's something that is Honorable Kela. Honorable Kela.
Thank you very much, Chair. The question that I wanted to ask, it was asked by Honorable Jacob. So I'm covered, Chair. But I'm happy when the alcohol is banned because really it's also contributing negative towards COVID-19. Because really the issue of women and children abuse and killing of women is because of the alcohol. So I'm very happy and I'm just wishing that it could stay as it is until the lockdown, because really recently over the past month we saw the number were increasing because people when they are drunk they don't care actually what is happening, and the issue of social distancing it's not they are not complying with it because they are drunk. So I'm very happy, Chair. But also the other issue, Chair, it's an issue that has been raised by my colleagues that really we need to stand up and also come up with a recommendation, a strong recommendation, so that at least we understand, because also it contributes to a lot of death, the issue of alcohol. We are not safe actually, we are worried because really the issue of consumption of alcohol, it's also contribute negative to our South Africans. Thank you, Chair.
I think Honorable Janji, if she's around. I think I don't see her here. Honorable Al-Jama.
Thank you very much, Honorable Chair. Honorable Chair, I attended a Portfolio Committee meeting for Small Business Development earlier today, and the Minister was very revolutionary when she slammed the Western Cape as the main culprit, and the research from the Western Cape is one of the main reasons why there is now a ban on the sale of alcohol. It is shocking, Honorable Chair, that the Western Cape has had a very progressive policy to reduce alcohol trading hours and in that way reduce alcohol harm. And we welcomed it because we're from the Western Cape. In the Western Cape, Honorable Chair, we do have certain towns where it is alcohol-free. I lived in Fishhoek. It was alcohol-free. I'm now living in Pinelands, alcohol-free areas. And, you know, maybe it is time that even South Africa become an alcohol-free country. We cannot have an economy that is destroyed by alcohol, and we are going to very soon roll out in terms of the NHI many health facilities in the rural areas all over South Africa, and we know it's going to be very expensive and costly, but it is something that has to be done. We cannot allow that these health facilities that we are going to establish are going to largely serve people as a result of their drinking habits. We are not going to roll out the NHI, Honorable Chair, to undo the harm that is being done by alcohol. We need to move in the direction of an economy where wine does not play a very important role. And that is the most revolutionary step that we as South Africans can make. And I'm very glad that the Health Portfolio Committee is setting the lead as far as sending the message out that South Africans must drink less, that there must be less trading hours in alcohol, and we can learn a lot of valuable lessons from the pandemic in that regard. So I have a lot of hope for the country, for transformation, in that our leadership is now taking this very strong stand. I know in the 60s and 70s, there was already a call by our revolutionary leaders that we need to do something about alcohol drinking and reducing alcohol hours, because more alcohol trading hours increases alcohol harm. That is the research from all over the world, which has now been confirmed. Thank you very much, Honorable Chair.
Honorable Al-Jama, don't raise your hopes too much. Let us hope that we as legislators here are going to not only listen to this presentation, but are going to make a meaningful strides out of it. It's not just for us to listen to it, but we need to formulate what actually programs do we put in place for the country, because we happen to be those legislatures that are actually to do with health and an impact on alcohol. So let's do something. Honorable Munyai.
Honorable Chairperson, with greatest humility, allow me to what is the problem, Chairperson, now? Honorable Chairperson, with greatest humility, allow me to extend our greatest appreciation to Professor Glenda Gray and Professor Richard Perry for saving life in the Republic of South Africa through science. And from the ANC point of view, in South Africa, we are not going to apply Sharia law based on religion, but based on science. We're going to listen to scientists, not emotions, not religion, but scientists. Honorable Chairperson, we agree with MRC research as a whole. Number one, that we agree with MRC that advertisement lure the young people to not only to smoke, but to drink alcohol at early ages. We further agree with MRC that indeed alcohol contributes to disability or for people to die early with disability. We agree that the one point, Chairperson, from the ANC point of view and from the Constitution of the Republic of South Africa, no individual rights will supersede the right to life. The right to life, Honorable Chairperson, supersedes all any other rights, including the right just to drink and the right to move. So on that context, we will not agree that any other rights to undermine the right of life. We agree with all the scientific report that has been put forward and the recommendation. What is critical, Honorable Chairperson, is that we have to take active part in leadership to make sure that we develop policies that will be able to help us and save our people. But what is critical is to raise, and I think I must commend Professor Perry about the risk adjusted. You don't just apply law, because law is, drinking is not static. Our situation is not static. Risk adjusted implementation of policy, it will be very much important during a pandemic. So therefore, policies I agree with, amongst others, that we need to implement to be able to ban the advertisement, especially at the with the sporting in the match, soccer, rugby, cricket, and so on, because people think that they're playing a good rugby because they're drinking alcohol or just lager. These have to be banned, except at the point of sale. So we agree with the whole recommendation, and we're so honored that we still have institutions such as these that can serve the country in much more better way. Thank you very much, MRC team, and we're so honored. Thank you very much.
Is there any other member that I've left out who wanted to contribute?
Chair, I'm back.
Okay, who's that?
Ujanji.
Okay, yes, you are the last one. Come through, Ma'am Janji.
Thank you very much, Chairperson. I fully want to echo the same sentiment and thank the presenters for this wonderful presentation that has brought more light to us. And clearly, Chair, there is no health benefit that alcohol brings to the community. And therefore, I agree with Professor that we need to put up those strict restrictions of banning the advertisement, because they lure the young people to these advertisements. And also, I agree with them that we should put stricter policies. It should start at local level, where Mamchango was correct. You can't have people drinking in the streets and you do not do anything about it. It should be banned that people will carry liquor in the street. And I think, Chairperson, we also agree that we need. I'm not sure how much of an awareness campaign we can do that liquor is dangerous. And if the 30% that drinks in South Africa is bringing such havoc to us, how much if other people were drinking? You should have seen them when the liquor was opened on the third level. That it was like it's the New Year Eve. People, the way they were celebrating. I know that behavioral change is a very difficult thing to do, but I think us as the committee and us as parliamentarians, we should stand together and say, though people have rights, constitutional rights, but they cannot take away their responsibility and put other people in danger. Thank you very much, Chairperson.
Yeah, honorable members, may I make the following proposals and requests that we are close to 2 o'clock now. Unanimously, all of us have actually welcomed this presentation. I'm requesting that we put aside time to reflect on the recommendations and formulate our action plans as this committee. Among other things, it would be what are the immediate campaigns that we are going to be involved in, who are other committee members that we want to rope in and actually work with in the legislature, in the National Assembly. Who else do we touch base with? And we do that next week. But for now is to welcome this presentation and comment that it is a way that we would like to take forward this process, because it can't be a new, we are creating a new normal in our own country. And I like what was said by Honorable Nyai, that a right to life, a right for a South African to access an ICU bed must not be bestowed by a drunkard who decides to drink too much and drive a car and have an accident to say, I should be prioritized to get a bed in the ICU over and above a cancer survivor who needs to be given a bed in the ICU to get going and be able to be there for his or her family. Those rights must actually be worked into. All issues related to raising the ban of alcohol, the age, and also talking about, can we agree, honorable members, yes, I'm going to allow the professor just to comment briefly just before 2 o'clock for those that are pressing, but overall, a lot of you were actually raising appreciation and concerns how we take this process forward. I want to invite you that next week we put together our action plan as the committee based on this presentation as to what else we need to do as this legislature. But let me allow the Honorable the Professor just to comment briefly, very briefly, sir.
You mute, Charles, you mute. Still mute, you're still mute.
Okay, you can hear me now. Thank you. Just quickly, there are a lot of points here, but I think I can get through them very quickly. The point was made that there are many costs because before people get to the hospital. That's a point that needs to be picked up on, yes. Also to say that our modeling didn't include the primary healthcare facilities and the private hospitals. So the impact of a ban might even be greater. Honorable Sheikh talked about poverty, and certainly linked to the issue, it raised the issue, possibly people might trade down, but certainly our research is showing that something like minimum unit pricing would have an impact on the heaviest, poorest drinkers. So that's certainly something there. I can't go into too much detail. I've done more than 12, 15 years work of research in fetal alcohol syndrome, but I can't go into that today. In terms of the cost to the economy, I was going to ask Professor Matsopoulos to talk, but briefly, yes, there's done some research. It's a little bit outdated now, but certainly at that point in time, the economic costs to the country from alcohol do exceed what we gain from excise tax and VAT. In terms of young people, we need to look at interventions there. Probably the most effective are controls on advertising, raising price, and looking at, for example, drink driving for the 18-year-olds, more restrictions in that area there. We need to look at the issue of taverns. That was his last point, late at night. Look at the hours of sale. Maybe people, we've learned now, we've reduced the hours of sale now during the lockdown. Why don't we limit hours maybe to 11 o'clock at night, for example, 12 o'clock at night in urban areas, and even less in residential areas? That needs to be a point for discussion. Marketing, yes, I've talked a little bit about that. Tourism, packaging, walking around without packaging, that's something I haven't really thought about, certainly something to think about. Though we do know that one of the provisions of the Control of Marketing of Alcoholic Beverages Bill was that alcohol wouldn't be sold in a shop like a supermarket in a way that's visible to anybody else. It should be like a closed off area where you go in if you're over 18, separate turnstile, and then the alcohol's not visible as it's being sold. So maybe we should explore that option. Contribution of producers, certainly we should be looking at taking more of the revenue gained. Certainly what they did in Thailand was a 2% tax on beer and cigarettes, which they put into this health promotion fund. And we need to look at the industries, although they say they're not making a lot of profits, some of those profits are taken offshore. So we should look at the income stream, what's happening there, whether we can get more funding from industry to help pay for a more responsible situation. Then Honourable Wilson raised a number of points. Surely we should have improved the health system. Well, I can't really comment on that. I know certainly in the Western Cape where I come from, there was a lot done to improve the health system, and I guess it varied across the country. Freedom of choice. Well, we also have child rights as well. That was touched on by Honourable Munyai, and we need to look at other rights of other people, which sometimes also are being infringed when there's a lot of exposure, sports sponsorship to young people. So there are multiple rights that need to be looked at. Many suffering because of a few. That's a fallacy. In fact, what I showed earlier was that it's not just a few drinkers who are causing problems. It's potentially 50 to 60% of people who drink who are drinking irresponsibly sometimes. And so it's not just, the industry would like to say it's 5-10% of the drinkers who are causing a lot of the problems. Unfortunately, that's not the situation in South Africa. I'm not going to talk about smoking, black market. That's an issue to be addressed by the economic MAC. I won't talk about that. People making their own, yes, I think the government needs to get out more clear messaging about not using methanol. But I think there were under 20 people who died because of methanol poisoning during the 66-day period of the lockdown. That is an issue, and we need to encourage people not to use industrial alcohol at this time. Risk to the economy, of course, it's an issue when you have a ban on sales. That's something to be discussed. And I agreed with Honourable Wilson in terms of making sure we have treatment options available for addicted people. I think we could do better there. Honourable Hlengwa talks about GBV. Alcohol is one of the factors. There are other factors contributing to gender-based violence. The value to the economy, that's around the economic issues. I'm not sure we can push the whole thing back into a bottle and go back to prohibition. I think we need to look at having a more responsible, better regulated system. And I think we can do a lot without prohibiting alcohol, but controlling it better along the ideas that I put forward in my last table. It needs to be far better regulated, not prohibited. Almost done here. COVID-19, he talked about that. I think an issue we haven't talked about much is that the ban of alcohol sales through reducing the availability. And we know that reducing availability reduces consumption, which reduces harm. The WHO is very clear about that. It also is reducing the risk of community transmission of the virus. And so we are not only getting a saving in hospital beds, we'll potentially get a saving in reduced transmission of the virus, reduced gender-based violence, and also alcohol is linked to impaired lung health and immunity. So they'll also get some benefit there. The NHI, in fact, I was glad that the Honourable Jamar mentioned that. We've just recently completed a report, released a report on looking at various lifestyle issues and how addressing those can increase the potential for the NHI to be successful, looking at drinking, smoking, exercise, and obesity. So that report is available. We can just give it to the Honourable Committee. Almost done here. Around young people, controlling advertisements. Yes, it does get people to drink and drink more. Are we done now? Do you want me to stop?
Yeah, so that Professor Glenda can also be able to make one or two comments, please. Yeah.
Good. I've pretty much done now, so handing over. Thank you.
Yeah, I mean, I think what Charles has explained is that that we have not in South Africa over the last 2 decades, we haven't really paid much attention to alcohol and the way it's been propagated in South Africa, and that we need to have a national alcohol policy that's aligned to some of the recommendations, international recommendations, and that we should be paying attention in future to ways of minimizing alcohol abuse, increasing age. I think he was generous. I would have gone to 21. Increasing the age of alcohol, like in America, where you can only drink alcohol after the age of 21, and issues around the control of sales as well. So I do think that we have to have a responsible national alcohol policy, and that we should endeavour to promote responsible drinking, as well as trying to highlight what alcohol does do to our communities. It increases gender-based violence against children, and it also we don't have to have this carnage on the road because of alcohol-related accidents, which we see over the weekends and we see at night. And if you look at the data coming out, most of these accidents are happening over the weekends, in the evenings, and we need to curb drunken driving, to pay attention to speeding, and try our best to prevent all this carnage that's related to alcohol. And it's time for us to address this as South Africans, so that we can make sure we can control alcohol abuse in the country.
Honorable members, please do allow me to put the meeting to a close with this, that our action plan we are going to put together, but we might actually accept scientists to support us in refining it. I'm very much in support of what Professor Gray is saying. 19 might be okay, but 21 would just be the right one. So if we debate and say, of course, I mean, why would you allow a 19-year-old to say you can now start drinking? I mean, what on earth is that person going to be doing? That person is just an entry to a university. Hold on until at least you are halfway or done with your first degree. Then you can decide to then drink. So we can actually work around this. So may I request that, honorable members, we thank the team that has come in to support us. We have our own space to refine our thoughts, put our action plan. We'll invite them to look into what is our action plan looking like based on the recommendation that they are giving forward. Also think, honorable members, who else are we going to rope in terms of other portfolio committee members who are actually having a very important role to play in terms of alcohol regulation in the country and in National Assembly. Thank you very much. Please don't forget to log in an hour's time in a 3-line whip that is starting at 3 o'clock. Thank you very much and have a good day.
Thank you. Give the chair, long MRC, Prof. Gray and Perry.
Thank you.
Right.
Thank you. Bye.
Bye. Bye.
Bye, everyone.
Bye-bye.
Bye-bye, Chairperson.
Thank you. Bye, everyone. Keep well. Stay safe. Bye.
Bye, Kenny.
Bye, Pumza. Bye, Anna.
Bye, Pumza and Kenny.
Bye, Matlingwa.
Bye, Martha.